These are my conflicts of interest, and this is the outline of my talk. So it's heavily focused on key populations, men who have sex with men and transgender women, and as those are the populations that we work with, those are also the populations that carry the highest burden of HIV infection in Thailand and throughout this region, actually. So I will talk a little bit about gonorrhea and chlamydia, and I will focus on some data in HIV-infected and uninfected people from some studies that we did. Then I will talk a bit about diagnosis. I'll touch a bit on hepatitis C infection, and then I will end with talking about how to deliver these STI services. Okay, so to start with gonorrhea and chlamydia, I'm not going to talk about all the clinical and pathophysiology background, so I'm going to start by showing you this map. This is from a paper in the Lancet Infectious Diseases from 2 years ago, and it shows by WHO region the number of new STI infections per year. So I would like to draw your attention to our region, and as you can see, it is an incredibly high burden of disease. In Southeast Asia, we have, so this is by millions, by the way, we have 14 million new cases of chlamydia, 12 million new cases of gonorrhea, and in the Western Pacific region, it's a staggering 60 million new cases of chlamydia, 35 new cases of gonorrhea every year. So this is a very important problem, a big problem. I hope that we can all realize that. This I want to show you. This shows you the rates of new infections, HIV, syphilis, gonorrhea, chlamydia, among men who have sex with men in England, in the UK, starting from 1996 up to 2015. And I would like you to look at the green line for gonorrhea and the purple line for chlamydia. And as you can see, yes, it has been rapidly increasing, but that increase has started to happen 2 decades ago. So with that, I also want to address the potential elephant in the room. Yes, we know that PrEP increases STIs, but that increase of STIs was happening way before PrEP was even in the picture. So this is from 2 cohort studies that we did. The first column is showing HIV-negative MSM and transgender women who were enrolled in several hospitals in Thailand. This was in 2012-2013. And the last column shows you a larger cohort of HIV-negative MSM and transgender women who were enrolled a bit later in community-based organizations throughout the country. And I just want to get your attention for the rate of any STI, which is incredibly high, 25% up to 29%. Any gonorrhea was seen in almost 12% of people, and any chlamydia, meaning in any of the 3 compartments, in 18%. But what I've highlighted here is the rates of infection in the urethral compartment, which is very, very few, and the rates of anal infection, and for gonorrhea, pharyngeal infection is a lot higher than urethral infection. So very similar data, but a lot higher for HIV-positive MSM and transgender women. This is from the same cohorts. The first column shows you the baseline data of people who were HIV-negative at baseline and who seroconverted during the study. And we see that any STI is double, more than double, than among HIV-negative people, with up to 60% of people having any STI at baseline. Again, high rates of gonorrhea and chlamydia in any compartment, but again, the urethral burden of disease of gonorrhea and chlamydia is significantly lower than in the rectal compartment. So this is quite a serious problem, right, I would say. It is essential that we diagnose this correctly because, so yesterday during the great debate, it was mentioned that faster is not always better, but infectious diseases, it actually is, because quick treatment is the key to infection control. So we have to really make sure that we diagnose properly. So what should we do? Should we screen for symptoms? I really think not. In men, chlamydia and gonorrhea is mostly asymptomatic asymptomatic, and this is especially so for extragenital sites. So if you can think about all the people that you see in your clinics with discharge or dysuria, you have to multiply that by several factors to get an idea of the burden of the disease. Then there is rapid tests, several different rapid tests for chlamydia and gonorrhea in the market, in which you use a urine sample to detect the presence of chlamydia or gonorrhea. And we did a small validation study comparing it to our laboratory-based NAT. And as you can see, specificity is fine, but when we look at the sensitivity, it ranges from really, really terrible at 10% to, I guess it's okay at 60-something%. And I know that there are programs that use this Sti test kit, both for chlamydia and gonorrhea, for STI testing in high-risk MSM, but that's because you don't have another option. And if that is all that you have, then, by all means, use it. But what we really have to talk about is NAT, both laboratory-based NAT and point-of-care NAT. It's incredibly expensive. At the Thyroid Cross Anonymous Clinic, it's about $25 and this is per compartment. So what should we do then? Should we just do single compartment testing? Again, I think not. So I will walk you through this figure. This shows you from the same cohort study I mentioned earlier, in which we enrolled from community-based organizations. On the left, you see 1,600 MSM with 30% prevalence of either gonorrhea or chlamydia or both. And we can see that 42% of them only had rectal infection, 15% of them only had pharyngeal infection, and another 11% only had infection in the pharynx and the rectum. The percentage of urethral infection was about 20%. And when we look at transgender women, those differences are even more pronounced, with 54% of transgender women only having rectal infection of either gonorrhea or chlamydia, 20% having pharyngeal infection, and another 20% having both pharyngeal and rectal infection. So let's zoom in a little bit and let's look at gonorrhea among these MSM. Let's say that we would screen by one compartment. Let's say that we're going to ignore this and we're going to do urethral screening. We're going to miss 77% of all infections among this population. Then we can say, okay, so we have to focus on the rectum, but then you still miss 40% of all infections. And if you only focus on the pharynx, you're going to miss 55%. And that's very similar for chlamydia. If we only do urethral screening, we miss 67% of infection. Again, we can say, okay, so we have to focus on the rectum, but we will still miss a third of all infections. So single compartment screening is not really the way to go. So then, should we ask people which routes of sex they use and then test those? Again, I try to find a bit of an answer to this question, and my conclusion is no, we shouldn't do that. Pharyngeal gonorrhea is very commonly found in all types of populations who don't report that specific type of risk. And then when you ask about anorectal sex and then based on that collect samples for chlamydia or gonorrhea, has also a very poor sensitivity, and you're going to miss a lot of infection. So what, right? These are asymptomatic infections. I hope that no one agrees with me right now. Why do we care so much? Asymptomatic infections, even though we don't notice and everything's okay, they are transmitted. And as we've heard from Rebecca just now, underdiagnosis, undertreatment leads to AMR. It is already quite widespread. Everything we throw at gonorrhea, it develops resistance to quite rapidly, and especially extragenital infection is associated with acquisition of resistance. So then, I'm telling you all these things that we shouldn't do. So then, what should we do? We did a small validation study, again, at the Thyroid Cross Anonymous Clinic, in which we pooled samples. We collected samples from all three compartments, and we did 3 separate NATs, 3 separate gene experts, and then we pooled the NAT together, the samples of the NAT, and did a pooled NAT, and we did the same for the gene expert. And even though it's quite a small sample sample size, what we found is 100% concordance between the point of care and the lab-based NAT, and between pooled samples and separate samples, and no infections were missed. And this is kind of in line with what we see in the literature. This is from 2 studies from a couple of years ago, pooled NAT and MSM. Sensitivity for chlamydia detection is not different when you compare pooled samples to separate samples, and sensitivity for gonorrhea is a little bit less, but that could be because those cases that they are talking about here probably had a low infection load. So then there's another study that did the same thing, and they actually showed a good agreement, 94% for chlamydia and 100% for gonorrhea when you compare GeneXpert with the lab-based NAT. So that should really be something that we have to consider and have to include in our programs. And I will talk about service delivery at the end of my talk. So I want to bring up hepatitis C infection. Sexually transmitted hepatitis C infection has long been reported in HIV-infected MSM in Europe and in the States. And there are now reports that that is spreading to HIV-uninfected MSM who are starting PrEP, indicating that these sexual networks are linked, and this is just like a disaster waiting to happen, maybe. So I'm going to show you data from our cohort. This is the same cohort in which we enrolled from community-based organizations. The prevalence, so this was in 2015, 2016, and the prevalence of anti-Hep C at baseline was about 0.7, 0.8%. And that is very comparable to the general population in Thailand. People who were HIV positive almost had a twice as high prevalence, but it wasn't statistically significant. And independent predictors for having prevalent Hep C were older age, having active syphilis, and using amphetamine-type stimulants, or ATS. So in this, So in this cohort, we also looked at incident infections, and that was very low. So again, this is like four years ago. There were only 2 incident infections over about 1,200 person years. One of the 2 also seroconverted for HIV at the time that they acquired Hep C. But so nothing alarming so far. So now I want to show you data from another cohort, which Dr. Eugene and Dr. Denise talked about yesterday during the plenary session. This is the acute HIV cohort, which enrolls MSM who have acute HIV infection, which started in 2009. And up until October last year, they had about 573 patients. And these patients are closely followed. They get yearly anti-HCV, they get regular lab testing, liver enzyme testing. And what's interesting is that between 2009 and 2013, there were 0 incident Hep C infections. A couple of years later, between 2014 and 2016, this was at about 8 per 1,000 person years. 2017, it has further increased to about 27, and last year it reached a staggering 33 incident hepatitis C cases per 1,000 person years. And in this cohort, independent predictors for incident hepatitis C infection, again, were methamphetamine use and engaging in group sex. So we have another cohort study in which we enroll 4 groups of people who are HIV negative and do or do not use ATS, and people who are HIV positive and do not use ATS. And the outcome of this study is to look at the effect of ATS on things like viral suppression, ART adherence, PrEP uptake and adherence. But of course, we also do hepatitis C testing. So here I want to show you the difference in hepatitis C prevalence at baseline among these 4 different groups of people. And it's very quite obvious that with people who are HIV negative and do not use ATS, they don't have anti-Hep C positivity at baseline, but with HIV positivity and with ATS use, this increases to up to 15% among people who are both HIV positive and report to use ATS. So then what should we do with all this information? So if you've attended any session at this conference, this should sound very, very familiar. This is the main model through which we deliver our health services, KPLHS, or Key Population-Led Health Services. It's a model of services that we're implementing in community-based organizations, in which the services that we provide are defined together with the community. Then we train community health providers to be able to provide these services. And because the services are identified by the community, they are needs-based and they're centered on the client. These services are delivered in very close partnership with local public health hospitals and provincial health offices. So these are not just standalone services. And this is then what that looks like. The services that can be delivered through this model, key population community health workers can do reach and recruit activities. They can do testing, HIV testing, including confirmation test at the CBO, excuse me. They can do point-of-care CD4 testing. For people who are negative, they will be engaged in prevention services. PrEP will be offered. If PrEP is not accepted, they will be engaged in HIV testing services. And if PrEP is accepted, then the community health worker can provide same-day PrEP, and the client doesn't see a doctor. And then they are retained in care and in HIV prevention services. For clients who are tested HIV positive, they are immediately linked to care, again, through these close collaborations that we have with the local hospitals. And once clients are stable and they're virologically suppressed for 6 months to a year, they can be referred back then to the CBO, and they can start receiving the ART refills in the CBO rather than the hospitals. And we have implemented different types of these models, ranging from alternate visits between the CBO and the hospital to one model in which the client only has to go to the CBO and never sees a doctor unless something is wrong. So this provides a very good framework to integrate STI services. And what we are doing and have planned to implement is to integrate STI testing, obviously in the test part when people come in for baseline, provide point-of-care chlamydia and gonorrhea testing, as well as point-of-care rapid hepatitis C testing. And in the retention part, we will provide STI services, STI testing, to keep people into services and to keep them coming back. Okay, so this is my proposed, to answer the question of the title of my talk, this is my proposed STI package for MSM and transgender women. And here I have removed, because originally the title is for low and middle income countries, but I think we have to just block that out for now. Yes, we have less resources, right, than other countries, but that's not a reason not to prioritize these services. It means that we have to work harder, it means that we have to talk to more people, it means that we have to do more work, but we have to do it. We cannot afford to say, we don't have the resources, so we're just gonna make do with what we have right now. So this is obviously for our setting, but what I would like you to do is think about your own setting and how you deliver your services and how STIs could be integrated into that service. So for HIV positive people, HIV negative people, it is quite similar. HIV positive, for HIV positive people, STI services could and should be integrated with ART services, whether that's differentiated ART refill at a CBO or an after-hour clinics, or whether that is in your own hospital. It should be together. We should not provide STI services separately from any HIV services. And for HIV negative services, it should be integrated with HIV testing. And for people who are on PrEP, it should be integrated with PrEP services. If anything, from the rising incidence of STIs in PrEP, it shows us that PrEP gives us a beautiful opportunity to take it and to start using STI services in PrEP services. So again, these are quite similar. The difference is that for HIV negative people, I have added HIV testing, of course, but we should do counseling, condoms, lubricants. We should assess risk behavior. I don't know if you agree with me, but I feel like we don't really talk to our our patients to this extent. And if you don't know, if the person who's sitting across from you engages in chemsex, uses ATS, does anything, then you will not be able to identify whether or not this person needs to be screened for hepatitis C. So you have to address that. You have to be able to talk about that. So I've mentioned the Assist here, which is a screening tool for substance used by the WHO. It takes about 5 to 10 minutes, but it gives you a really good idea of if someone is at low, moderate, or high risk of substance abuse, and it gives you a brief intervention that you can apply or refer to a specialist. So apart from that, we should do 3 to 6 monthly syphilis testing, 3 to 6 monthly chlamydia and gonorrhea testing by pooled NAT, yearly anti-HCV for people who are HIV positive, and for people who are HIV negative, and you do know that they're using drugs, they're doing group sex, they're doing chemsex. We should also do yearly anti-HCV for HIV negative people. Referral systems need to be in place before you do things like an Assist. You have to have someone that you can refer someone to who has a substance abuse problem. You also need to ensure that your referral systems for STI treatment are in place and that you can provide same-day treatment where possible. So that's the minimum package, and then I also made a slide with the optimal or upgraded or platinum package, or however you want it. And that, again, the difference here is HIV self-testing services for HIV negative people integrated in PrEP service, blood-based HIV self-testing in PrEP programs, self-collected STI samples. Self-collection of samples is another very important, very useful tool to engage people into these STI services. And you shouldn't wait until your STI service is in place and finished and ready and then start thinking about self-collection of samples. Do it now. Just start doing it, because this is, if you don't, you're missing out on an additional set of clients that otherwise you would not reach. Vaccinations, mental health, of course, that also ties in with the drug use, but we should be able to talk to our patients about their sexual health and their sexual pleasure. Sex is supposed to be nice and good, and it should make us happy. And if we all pretend that it's something wrong and we shouldn't talk about it, then people are not going to come back to your care. Partner notification services and expedited treatment for partners. And of course, you have to tailor this further to who your target population is. So if you're working with PWID, you have to add harm reduction and needle exchange. If you're working with women of childbearing potential, you add reproductive services into this package. If your target is transgender women, you add gender-affirming healthcare. So in conclusion, we have a really high burden of gonorrhea and chlamydia, and we have to make this a public health priority. We are the ones who have to say, we're going to put this up there with HIV in terms of what we want for funding for treatment. We need to screen regularly. Even for low-middle income countries, we cannot afford not to screen, and pooled screening with NAT should be the way to go and should be what we should aim for. We have to work together to try to reduce pricing by regional bulk pricing, bulk purchasing. We cannot allow companies to decide for us that we cannot do NAT for our clients because, it's too expensive and we cannot provide these services. We have to find a way to try to reduce those prices. In our region, there might not be a lot, but there certainly are a few research institutions that have the capacity, the capability to initiate research or for cheaper and better STI diagnostics. And this is really something that we have to prioritize as well. And self-collected samples is an additional tool to reach more people and get more people into STI services. Don't forget about hepatitis C. I know you probably wouldn't, but I just want to reiterate that. Talk to your patients and see and identify who should be tested for hepatitis C, and integrate everything within your existing models so that we can approach sexual health in specifically, but health in general in a holistic way. Thank you very much.